Professor Mathur, sir, are you there?
Yeah, just I'm joining. Yeah, I'm here.
Yes, yes, yes. So let's wait 1 minute for the speaker to be here and then we'll start the session,
Okay,
sir.
okay.
He will be he's there, he'll be coming in a minute.
Yeah, I can see the speaker, Dr. Vijay Singh.
Sir, our speaker is here, Professor Vijay P. Singh. Professor Vijay, can you please unmute your mic?
Yes, absolutely. Can you hear me?
Yes,
Good
yes.
morning, good morning. Welcome
Good
to
morning.
Covinar Pondicherry University. I'm very happy that you are present today and would be talking something related to COVID-19 and the kind of work which you have done in recently. And I will not be able to attend the whole meeting because I have to go to the campus and then I will be driving. So I wish all the best to the participants, and it's a large meeting. Rukmini will be taking care of that. More than 1,000 people got registered themselves, and many of them are our own students, but there are many people, those who are from outside. I think she may have some data later on. And I am very happy, and the Mayo Clinic actually is a very famous institution of the US. And in fact, when I was in KIT, we established an MOU with Mayo Clinic there. And I don't know what is the status of that, but it was quite a successful one with some
We accidentally lost the connection, it
I
seems.
think, yes, yes, yes. So he's back now, but
Well, it's a very kind welcome. Thank you so much. It's an honor and a pleasure to be here to share what we can as we battle this horrendous disease. And I would love to share our thoughts and discuss and get some feedback also. Thank
yes,
you.
yes. So let's now start the session, sir. A very good morning, everybody. I welcome you all to the next interesting session of the week-long international webinar on COVID-19, Covinar, organized by Department of Biochemistry and Molecular Biology, Pondicherry University. Today we have with us an expert physician and eminent researcher, Professor Vijay P. Singh. Professor Vijay P. Singh is the Professor of Medicine and Professor of Biochemistry and Molecular Biology in Mayo Clinic Graduate School of Biomedical Sciences, Arizona, USA. He completed his medical graduation and post-graduation from PG Chandigarh and carried out his postdoctoral research in Harvard Medical School, Boston. He has received several honors and awards throughout his studies. He was also teaching in various universities like Harvard Medical School and University of Pittsburgh. He has received 16 research grants and have got 8 patents, of which 6 are commercialized. He has presented around 65 research papers in various conferences and published about 62 papers in reputed journals. I just have to say, of which around 10 is in gastroenterology, and I would like to mention here the impact factor is 21. He's also the reviewer and editorial members in various prestigious journals. So we are very honored by your presence here, sir, and I kindly request you to please deliver your lecture. Thank you very much.
Thank you so much for the very kind introduction, Rukmani. It's a pleasure to be here and share our thoughts on COVID-19. And as we work towards combating it, I will now go to the main screen. Let me maximize it if I can. There we are. Can you see the full screen now?
Yes, sir.
Hello? Okay, good, perfect. Okay, so we'll be talking on the lipotoxic exacerbation of COVID-19 and some simple interventions that may help to improve outcomes. And these simple interventions are a part of supportive care, supportive medical care that could help. This does not replace an antiviral therapy if your physician is planning to give it. Doesn't replace critical care if a patient needs a ventilator. This is all supportive care, and let me emphasize over here, this is mostly applicable to the early part of the disease. And we will now build a hypothesis about how we came to this conclusion that early intervention by simple interventions may help in improving outcomes. So let's start with the first part. There are some icons on the top. Is there a way to get rid of them? These are all related to, I believe, the Zoom part. Is there a way to get rid of the Zoom icons on top? Would you know that?
I think we cannot, because you're sharing the screen. It is shared sharing
Okay,
icon.
that's fine. So the title is getting covered over here. I don't know if you can see the title of the slide, but what it says is basically
We
this
can
is
see from here, sir. We can see.
okay. Okay, so this preliminary part and how the acute outcomes in COVID-19 typically come out once the disease sets in. So the point to keep in mind is COVID-19 is an acute disease. It progresses over days to weeks. It's not a chronic disease like diabetes over several months or years. And if you look at the literature, while the consensus is still evolving, in the green you see that about 40 to 50% of patients can be asymptomatic. And there are 3 papers I quote over here in a systematic review. And then among those which are diagnosed, which would be 50 to 70% of patients, majority have a mild course. So it's 60 to 90% would probably have some respiratory symptoms, which would resolve over time on their own over a few weeks. But 10 to 35 can be severe, and in 0.1 to 10%, it can be lethal. So this brings up an interesting paradigm that most people who are infected with COVID-19 will clear the infection on their own, whereas it's a minority which will not clear that infection and progress to severe disease and unfortunately sometimes to death. And this is without any effective antiviral therapies. This is without any vaccine. So what is there to learn in that dichotomy of 10%, let's say, developing severe disease versus 90% developing mild disease? And this is just a simple summary over there. That let's say we start with 1,000 cases, 400 may be totally asymptomatic, 600 may be symptomatic. Among those, mostly it'll be mild, shown in blue, and maybe about, let's say, rounded off to 200 may be severe, and then unfortunately 1 to 70 among them may die. So the question is why and how can we prevent this? So let's start again. So that's our breakup at the top about how the disease course may eventually evolve. And let's think of the modifiers that could make the disease go severe. So if you look at the epidemiological data, there are some modifiers which you cannot change. For example, age or the male sex. They say, yes, males are more predisposed to severe outcomes. But there is one modifier that could be changed, and that is obesity. Yes, you can say the person is already obese. How can you change it in a day or two? You cannot. But that is a modifier that is something that it's not fixed in time. It's not the gender of a person. It is something that a person acquired over time. And if you look at the data as it is split, body mass index cutoffs vary from country to country, but it's obesity that increased the odds ratio shown as this OR by a very significant part, like 12, 5.7, 3.8, and all the confidence intervals are above 1. And these patients develop severe disease. So the question is, what is severe COVID-19? Severe COVID-19 is basically the progression of the disease to multi-system organ failure. So multi-system organ failure is all the vital systems failing. So cardiovascular failure is shock. So there's vascular leak, and there are arrhythmias that we know that people develop that can lead to shock. There can be kidney injury. There can be lung injury. There's an immune failure that occurs and secondary infections develop. And these culminate in a picture of severe sepsis or death. My area of research till now has been acute pancreatitis. I've worked in pancreatitis for about 22 years now. And as COVID-19 was getting clinically profiled and we were hearing what happens in the disease, there were astounding similarities that we saw came up between COVID-19 and acute pancreatitis. Well, let's look at the similarities and what we can learn from here. And I'll come to on later slides how the two relate up and what we can extrapolate from the disease process. Well, first of all, both are worsened by obesity. There's abundant literature to say that acute pancreatitis is worsened by obesity. Both are acute diseases. Both start suddenly. Within a day or two, they start and they progress. And they progress rapidly. And in severe cases, it can become lethal, as we've seen. And severity, again, is a minority in both scenarios. 10 to 30% are severe. Most of them are mild. Severity has multi-system organ failure, or MSOF, associated with it in both diseases. Both have a cytokine storm. Both share hypocalcemia, that serum calcium drops. Both share hypoalbuminemia, serum albumin drops at the same time. And there is no other endocrine metabolic explanation for the simultaneous drop in both. No vitamin D or parathyroid hormone can explain the simultaneous drop in both occurring in both diseases. And both have fat involvement. So what is there to learn from in pancreatitis? As we said, pancreatitis is going to be worse when there is obesity associated with it. We said that triggers cytokine storm, and it can lead to multi-system organ failure. And those are the scary things in COVID-19 also. So normally, if you think of the pancreas, I've just had dinner and you've probably had breakfast a few hours ago. The food we eat, when it goes down the stomach and then beyond that into the intestine, the pancreas is the gland that normally pours its secretions into the intestine to digest our food. It breaks all the macromolecules into the small molecules like amino acids, glucose, fatty acids, which we then absorb and then either utilize or store. But when there's pancreatitis, there's spillage of its enzymes into the surrounding environment. The pancreas sits in our belly. It's like the size of a banana. So imagine it leaking out into the surrounding fat. And here we show it descriptively, the yellow fat surrounding the pancreas and this brownish area where there's spillage of enzymes into the fat. So, and if we zoom into it a little bit more, you see these pink colored cells of the pancreas. Normally they would have been secreting into this area where you see this red arrow. That's the apical part of the cells. They would have been secreting their enzymes into that duct, and the duct would have been bringing it into the duodenum where we digest our food. But when there's pancreatitis, you see this basal spilling of these blue dots and red dots coming from those cells. And that spills into the surrounding fat. And the surrounding fat, the normal fat, if it were unaffected, looks like the ones you see on the left side, normal adipocytes. And 80 to 90% of an adipocyte's mass is triglyceride. It's glycerol backbone with 3 fatty acids coming off that glycerol backbone. So suppose I have 10 kilos of fat in my belly, I probably have 8 kilograms of triglyceride sitting in my belly. That's a lot of triglyceride. But it's all safe and it's stored. But once there's a leakage of these enzymes, there are phospholipase and other enzymes that leak out that can damage the plasma membrane of these adipocytes. So you see them all damaged. And PNLIP, which is a pancreatic lipase, that's just one example here, that can leak and cause damage and break down the triglycerides into these wavy red little things you see over here, which are fatty acids. These are unsaturated non-esterified fatty acids, which are hydrolyzed more, as we will see. And when they enter the circulation, they can cause the whole spectrum of multi-system organ failure. For example, cytokines can go up, interleukin-6, MCP1, TNF-alpha, which is called the cytokine storm. Both in pancreatitis and COVID-19, there's a dramatic increase, and we look at evidence of that. There is ARDS, or acute respiratory distress syndrome. The lungs can get injured. There's acute renal failure, kidney failure. There's cardiovascular failure. So very similar spectrum happening in pancreatitis to what happens in COVID-19, very acutely, and both are influenced by obesity and fat. So what would the relationship be mechanistically between COVID-19 and fat? And let's look at the evidence that could be there. Now, again, the disease is still evolving. The strongest evidence, and we'll look at that, would have been autopsy evidence, and we'll look at what's published on that. So let's start and go back to the SARS epidemic about 14, 15 years ago that happened. At that time, autopsies were done, and they did find the SARS coronavirus in the exocrine pancreas. This you see in autopsies of human samples. In the exocrine pancreas, you see the brownish staining over here in the upper panel. Recently, there have been autopsies done in COVID-19 patients who have died from COVID-19. 5 out of 11 of them had focal pancreatitis or fat necrosis, the same phenomenon we saw in the back slide. previous slide, is taking place. That's fat necrosis, fat dying and releasing fatty acids. Additionally, recent studies have shown that patients who have severe COVID-19, some of them may have pancreatic enzyme level elevation. Not all of them. Again, there's a caveat to this. Lipase, the way we do it biochemically, is not the perfect test. It doesn't catch all lipase elevation. There are 10 types of lipases we have. So it doesn't catch all the lipases that can go up. And then it's not optimized for all assays. So yes, subsegment of COVID-19 patients do have lipase elevation. And lastly, the ACE2 receptor for COVID-19 is also highly expressed in adipose tissue, which has another lipase called ATGL, which we'll discuss in a few slides later, adipocyte triglyceride lipase, which can also break down fat. And the assays we do in blood are not optimized for ATGL. So just a quick glimpse at the previous slide, that basically the damage in pancreatitis, as you see over here, is being mediated by the fatty acids. And you may say, now, provide us evidence that fatty acids can actually do this. Where is the evidence that this happens? Where is the evidence that the cytokine storm happens? Where is the evidence that fatty acids can cause organ failure? Obviously, we cannot do that in a human. It's unethical. But the closest surrogate that we can test it in is in murine species. And if you look there, we do see cytokine storm. So if we give oleic acid to mice, and this was published in JCI just a few months ago, CON is control mice, O is oleic acid treated mice, and oleic acid is the highest abundance fatty acid within us. C18-1 is about 30 to 50% of the fatty acid pool that exists in a typical human being. Okay, so if I have 10 kilos of fat, I have 3 to 5 kilos of oleic acid sitting in that. So when we hydrolyze it or we give it to a mouse, serum oleic acid levels go up. Look at interleukin 6. It's about 1,000-fold elevation that you can get. Cytokine storm. MCP1, about 100-fold elevation. TNF-alpha, about 10-fold elevation. All the typical spectrum of a cytokine storm can be just induced by oleic acid, an unsaturated fatty acid. The other thing we talked about was hypocalcemia. We said that calcium drops. What's the evidence? And we'll come back to this again later, but if you focus on the lower panel on the left side, that greenish spiky appearance that you see is an interaction between calcium and linoleic acid, C18-2, an essential fatty acid, only dietary derived. We cannot make it, only comes from food, which normally is nowadays is comprising 15 to 25% of human visceral fat, has a very strong interaction with calcium. You see that this is a thermogram from ITC that you see over here. If you give linoleic acid or oleic acid to a mouse, serum calcium drops. With this reaction, there's a drop. The pulse distension, as you see in E, that drops. Pulse distension is carotid pulse distension, a marker of shock. They go into shock with linoleic acid. Serum blood urea nitrogen goes up, so they go into renal failure with linoleic acid. So the whole spectrum of cytokine storm, as you see above, and organ failure, shock, renal failure, and along with that hypocalcemia can be precipitated by unsaturated fatty acids. Not only that, let's look at the similarities. Now, this paper on the left side I'm quoting, I've taken a table from there, and I'm comparing that to the table on the right side, which is what is happening in mice. So the table on the left is human data from a paper published in Lancet. The table on the right is mouse data as to what we measured and published. And let's look at each parameter one by one. So in the non-survivors, if we focus on that middle panel in the human data, what do we see? Albumin goes down, so there's hypoalbuminemia. If you look at the paper below, which I'm referencing over here, and a few more papers have come since then, serum calcium drops. Lymphocyte count goes down. Platelet count drops. ALT goes up. Creatinine goes up, which is renal failure, and IL-6 goes up. And now if we take all these things and focus exactly on the same parameters in mice given C18-1 or C18-2, that is linoleic acid or oleic acid, both unsaturated fatty acids. And you look at, let's say, the upper panel, which is tunnel positive cells in the spleen white top. Those are T lymphocytes. And you look at apoptosis in them, you see a very significant increase in apoptosis by those fatty acids. Same thing, platelet count drops in these mice to about half. Serum albumin drops to about half. Serum ALT goes up. BUN goes up. Interleukin 6 goes up. And the same thing we see is what is mentioned in the two papers below, that is hypocalcemia, leukopenia, shock, and death. All of them take place with these fatty acids in mice. Fundamental difference is that saturated fatty acids do not cause that. So it's selectively the unsaturated fatty acids that cause that. So let's move now from the research scenario to the clinical scenario. So this is what we published at that time. We had followed about 15 patients who came to the hospital, were not sick enough to go to the ICU, and we just followed their course as to what happens over time with them. So in green are the patients who were dismissed home. And in red are the patients who either went to the ICU or died. And there are three panels here. The uppermost panel is the lowest oxygen saturation on pulse oximetry for the day that is plotted. Second panel is serum calcium, and third panel is serum albumin. And the line to really focus on is the one coming up from the zero, this thick dashed line. That is the day of the event, the day they either went home or they went to the ICU. And what you can see is that the trends in the red lines, the trends start much before the event. It is not that the oxygen saturation only dropped on the day that they went to the ICU. It had started dropping earlier. The serum calcium had started dropping about 4 days before. Serum albumin had started dropping much before. So all of these precede the severity that results in the patient going to the ICU. These are all early events saying that calcium and albumin are getting consumed much before the disease becomes severe enough for the patient to go to the ICU. That perhaps gives us a window period, whether it be prognostic in saying, hey, this patient's going to go to the ICU or get really sick, or perhaps therapeutic. And we'll look into why this perhaps could be a therapeutic option to decrease severity. All supportive care, again, as I said earlier, this doesn't take away the definitive care that the physician is doing. This is all supportive care to prevent the course from getting severe early in the disease, early, not late, early in the disease. Now, more direct proof before we go on to the logics of this is presented over here. So this graph here basically shows the PF ratio. PF ratio is partial pressure of oxygen in the arterial blood divided by FiO2. That is the percentage of oxygen that we are inhaling. So a good PF ratio means good oxygen of arterial blood and a high PF ratio. And what you can see is that serum unbound fatty acids in the patients who have good PF ratios, that is high PF ratios, are low. So there's an inverse relationship versus the ones who have a low PF ratio, that is poor oxygenation in the lungs, have high unbound fatty acids. And unbound fatty acids, what we find, are largely unsaturated. So this gives mechanistic proof or a more stronger association that in severe patients have a higher percentage of these fatty acids, which, as we see, are potentially neutralized by, can be neutralized by calcium or albumin before they become unbound, this form that we see. So since, as I mentioned earlier, linoleic acid is dietary derived, we cannot saturate a fatty acid or an unsaturated fatty acid once we've consumed it. We can unsaturate palmitate to palmitoleate or stearate to oleate, but we cannot remove the double bond, at least by conventional wisdom that we have. More so, linoleic acid we can't make. It's an essential fatty acid. So if they're coming from the diet. So the logic was, can we then trace a dietary association between severity of COVID-19 and the diet intake? And at that time, when we were doing the study, which was late March, early April, the epidemiology was all coming on a national basis, that so and so is the mortality in this country, so many cases, and so on and so forth. So we went to the Food and Agricultural Organization database, FAO Stat, and you can go there too. It's open access. You don't need any password. You don't need any fees to pay over there. You can go, and these are the highlighted, blue highlighted areas which we searched. For example, United States data, we looked at the food supply in kilograms per capita per year. We focused on various fats that was consumed per capita per year in that country for the year 2017. And this is the table that you'll download as a CSV file. And then we took this data for 14 consecutive days for every country that had more than 1,000 COVID-19 cases reported. So starting on March 25th till April 8th, this is the green shaded area. This was the sad time when we were seeing this mortality of COVID-19 going up so steeply. This is the daily deaths taking place. After that, as you see, the curve has flattened out. At that time, there were not sufficient ventilators. We didn't know what to do with COVID-19. We still don't know. But this was when mortality was accelerating. And it is in this phase that we looked at every day's mortality for every country with more than 1,000 cases. And by the end of the study, which was 8th of April, there were 61 countries, and it was totaling more than 1.4 million cases. And then we did an analysis of, compared this to various other risk factors, 11 other risk factors. First, we did a univariate analysis shown over here in this table over here. So the other parameters were COVID-19 testing parameters that, or COVID-19 characteristics, like how many cases per million there are, how many patients are being tested in that country, what is the total number of tests done, the resources in that country. For example, what is the number of hospital beds per 1,000 population? What is the number of ICU beds? What's the number of documented ventilators? Also, their dietary consumption. What is the amount of saturated fat in kilograms per capita per year, or the percentage of unsaturated fat? We other looked at economic parameters like per capita GDP, population density, etc. So we looked at all these parameters and initially did a univariate analysis. And what you see over here is the rate ratio. So a rate ratio is taking one means like 100%. And if the confidence interval, the 95% confidence interval, does not cross one, then, and it is a p-value of 0.5 or less, then it's significant. So what we saw was saturated fat was 0.97. So about a 3% reduction in mortality from whatever the baseline is with every 1 kilogram per capita per year increase in saturated fat intake. And the confidence interval did not cross one. Similarly, for unsaturated fat, it was 1.02, that is a 2% increase in mortality for every percentage increase in unsaturated fat in the diet. And as you see, this was significant on multivariate analysis, percentage unsaturated fat intake, which again is the oleic acid, linoleic acid that we talked about. And if we go further and do more in-depth analysis and look at it from a graphical standpoint, these are the kind of curves we get. That as on the left side, you see percentage unsaturated fat intake, as it goes up, so does the mortality. And the reverse thing we see is for saturated fat intake. So question comes, how is this all happening? What am I talking about here? You know, well, I'm talking saturated, unsaturated. I'm saying fatty acid scale. How does this translate? Okay, if I eat that, stored in my adipocytes, but what's it mechanistically doing? So yes, so if we eat, what we store in our adipocytes is this triglyceride. You see this, you know, E-shaped structures that are triglycerides. And now if we do a molecular docking of these triglycerides into, here we chose adipocyte triglyceride lipase, that's the adipose lipase ATGL. On the left side is the triglyceride of linoleic acid, so 3 linoleic acids, 3 18-2s on the glycerol backbone, pure LLL. And what you see is it docks in very nicely into the catalytic pocket. And the serine, catalytic serine over here with the carbonyl, first carbonyl carbon of LLL, that's 7 angstrom distance. But if we replace, let's say, the linoleic acid with the palmitate, the glide score goes down pretty significantly. And over here, you can see that the docking is also, the distance between that serine and the carbonyl carbon goes up. So saturation interferes with the fit of a triglyceride into the catalytic pocket of lipases. So once a fatty acid is formed, what does it do? Let's focus on the cells that are related to organ failure. So if my endothelial cells are damaged, I will have vascular leak. I'll third space fluid, my blood pressure will drop, and I'll go into shock. And here, indeed, we see endothelial cells, the transepithelial electrical resistance, that is the resistance across the endothelium. If we take normal as 100% nice tight junctions, that breaks up with oleic acid and linoleic acid. So the resistance breaks, the tight junctions break. Permeability to large molecular weight things goes up. So this is 10 kilodantal dextran, and you see LA and OA cause this to happen, but not PA. Let's look at immune cell injury. So these are PBMCs, or peripheral blood mononuclear cells, which would include macrophages as well as lymphocytes. And you look at an XN5 positivity, which is dead cells, significantly increased by LA and OA. So if that fat in my belly breaks down with the lipase, releasing these, I'm going to start damaging my endothelial cells. I'm going to start damaging my immune cells. We've heard about arrhythmias, and there you go. So these are cardiomyocytes. So basically, cardiomyocytes put on a dish and imaged with this green dye, which is a calcium-sensitive dye. And the upper two rows you see here are baseline before we add any linoleic acid. And you see nice rhythmic calcium oscillations, which are in the graph below on the left side of the graph. But then you add linoleic acid, the baseline goes up and the oscillations go into this fibrillation type of pattern. And we've heard arrhythmias, 30 to 40% of patients with COVID-19 have arrhythmias. There we go. You triggered it off in a Petri dish with an unsaturated fatty acid. So we've seen all the damage these can cause. Now let's look at the protective effect. We already looked at what calcium can do with linoleic acid. So it's a nice, strong exothermic reaction. The enthalpy is about minus 20 kilojoules, and it can react very well. Calcium and LA can react very well. And good part about calcium, it's a small molecule. It's molecular weight 40. So it can diffuse even into the tissue spaces and neutralize things. And that probably explains why we develop hypocalcemia as these fatty acids are being generated. Not only that, if you focus on B, which is below this green spiky graph, you can see that as in the red bars, as we go up in the calcium amount, we can prevent linoleic acid induced damage to these cells. You see the LDH leakage, that is the enzyme in the cytosol, lactate dehydrogenase. If it leaks out, it's damaged cells, but the damage goes down when you add calcium up front. On the right panels, you can see the reaction between albumin and linoleic acid. It's a much more powerful reaction, minus 314 kilojoules per mole. On an average, it's about 230 if you take 4 or 5 experiments together and average it out. It's about 12 times more potent than calcium in reacting. It's again a strong exothermic reaction, and it neutralizes it. But the point to learn over here is in the graph D, if you look carefully. So this graph, the y-axis shows the mitochondrial depolarization, damage to the mitochondria taking place after adding linoleic acid. So when you add C18-2, you see that red line starting to go up. Now, when I add albumin, if I add it early, I can flatten that line out, but I don't reverse it. The point is, if the damage has occurred, it's there. We cannot reverse mitochondrial damage once it occurred. We add it later, again, it stabilizes there, but doesn't reverse. And the same thing happens later on. So the albumin can prevent the fatty acid from causing further damage, but cannot reverse the damage that has already occurred. However, the other proof that we can look at it over here is directly over here. So we took cells, and in the left panel, we added the calcium and albumin after adding linoleic acid. And that's the third bar you see. LA plus albumin actually is LA plus calcium plus albumin. No different than the damage that LA itself or linoleic acid itself caused. However, if we had added calcium and albumin upfront before we added the linoleic acid, those powerful reactions, the enthalpies we saw, have already taken place. And because they take place, they don't let the damage happen and completely block it. So it has to be an early neutralization of these fatty acids that takes place. We cannot be successful if we do this late in the ICU. Patients already there on the ventilator. It's not going to work. It all has to be done much, much earlier if we are to see a benefit. And this is, again, I would like to say this is supportive care. This is not definitive care. This is not going to reverse injury. This is all, and this is not going to replace other treatments your physician is doing. So with this, we can say that calcium and albumin can neutralize these unsaturated fatty acids very well. One other important point of caution is here in this slide. A common thing taught in medical schools is the calcium albumin correction. And if there's one line I would like to say here is, don't follow that in COVID-19. In fact, we should not follow that in pancreatitis. And this is an example. So both hypocalcemia and hypoalbuminemia, as you saw, take place in this thing. And if we follow the calculator, and you can go to this calculator on any online thing, you just Google calcium albumin calculator, you'll go to WebMD or some other place where you can do this. So normal calcium is around 9, normal albumin is 4. And you say, okay, both are dropping. And I bring my calcium down to 6 and albumin to 0.1. It's incompatible with life. I've never seen a patient with such low parameters. But guess what? The calculator gives you a calcium of 9.1. It'll pseudo-normalize the calcium. So if we follow this logic, then we would never need to replace it. So therefore, this calculator is something to stay away from, perhaps, if we are planning to follow the strategy of supportive care in COVID-19. So the lesson over here is, when the calcium and albumin are dropping, the time for intervention is early, before ICU, not after that. It is all meant to be done early. The same with albumin. These will help if we do them early, or may help. I shouldn't say will help. Again, it's not that the patient already may have been sick for 10 days and then comes in, may not help. But this is the simplest supportive strategy that we can think of based on the scientific evidence we have. At this point, after the patient has gone into organ failure, it will be too late to help. So to summarize in this slide, we can say, and this is a part of the paper, which by the way is open access. The paper is at the bottom of these slides, the Gastroenterology 2020 May paper, which you see here. It's open access, anybody can download this. So if over time, with a diet rich in unsaturated fat, we enrich the adipose triglyceride with these unsaturated fatty acids, when there is going to be a lipase leak, and we don't know which lipase it is, maybe pancreatic, maybe adipose, I do not know which lipase it is, maybe something else. But when there is the breakdown of that fat, if it is already unsaturated triglyceride, we are going to preferentially generate unsaturated fatty acids, because as you remember, the fit of an unsaturated triglyceride in that catalytic pocket is better. Now, calcium and albumin will come to our rescue. So they'll neutralize these fatty acids as much as they can. But if I have 10 kilos of fat, that's a lot of fat to neutralize. My supply may run out, and that's what we say, supplement these if we can. Maybe they will help. But once the system gets overwhelmed, the unbound fatty acids go up. And once the unbound fatty acids go up, they start causing mitochondrial damage. We have published previously that complex 1 and 5 can get damaged in the mitochondria. ATP levels drop. There's necrosis. And once that happens, it's widespread. Endothelial cells damage, there's shock, epithelial cells, the kidney injury and the lung injury, inflammatory cells, impaired bacterial clearance. And then we have secondary infections on top. We never came in with those bacterial infections, but they develop later on. And that results in this cumulative picture of severe sepsis and death. And all this is happening over this 1 to 3 week period as the disease progresses. So based on the data that we have seen so far, the time for intervening is this green phase. This is the time when maintaining a normal calcium and albumin level may help decrease severity. This is the time, and I'm not saying that we give overdosing on calcium, I'm not saying 20 grams of calcium. It's just maintain a normal albumin and calcium. How it is done, it's all dependent on your local resources. Your physician can guide you on that. Maybe it is, they do a blood test outpatient and say, oh, come back next week. Or they may say, okay, do something about it. I'm not the judge here, how it is going to be done. And this is just a broad guideline about how it may work. So, but this is the period when maintaining a normal calcium and albumin may help decrease severity. However, as the disease progresses, when shock, organ failure, other things have already set in, when mitochondria are already damaged, as we saw earlier, you add albumin, nothing's going to happen. It'll flatten it out, but it's not going to reverse it. So post-organ failure, replacing calcium and albumin will have lesser benefit. So time for intervention may be earlier. So with that, I will close now, and thank you for giving me this opportunity to discuss with you all. I'll hand the stage back to the moderator. Thank you.
Thank you very much for this wonderful lecture. It was really very informative, and it will definitely help the researchers to design their research in newer directions. So now the session is open for discussion, and I request all the participants to post their questions in the chat box, and I request Dr. Subbalakshmi to moderate the session.
Thank you, Dr. Rukmani. Thank you, Professor Vijay Singh, for the excellent talk on lipotoxicity in COVID-19. I'm really very glad to meet you. Actually, I did my postdoc at Herbert Gaisano's lab on pancreatitis
Oh, my
at
God.
University of Toronto. Yeah, so I'm really very happy to hear your talk. And there are a lot of questions, and I have chosen some, and maybe we can start from Dr. M.M. Kesavalu. He asked, when pancreatitis is happening, whether insulin levels are also increasing, or is it only lipase that is increasing?
During pancreatitis, what we measure in the serum is serum lipase elevation or amylase elevation. So exocrine enzyme leak into the circulation is a well-known diagnostic tool for pancreatitis. Threefold above the upper limit of normal is what we call. And this, along with other features, is essential to make a diagnosis. As per the insulin part, there could be islet damage taking place in some scenarios. Yes, post-pancreatitis diabetes can take place. There is severe necrosis. 20 to 25% of patients can develop post-pancreatitis diabetes. Now, whether insulin will go up or go down is hard for me to say, because when an islet is being damaged, maybe it will leak its insulin. But once it's gone, the insulin may go down. So depends on what time you look at it. It's not been studied that systematically. But again, it's a subpopulation of people. Not everybody develops diabetes after pancreatitis. It's only in about 20 to 25% of severe cases.
Okay, thank you. We'll go for the next question. That is by Dr. C. Thirunavkarsu. He has asked, could you please explain choosing SFA C16 whereas UFA C18? Is this C16 and C18 is responsible for UFA toxicity?
Yeah, so the reason we chose the three fatty acids you saw were C16, C18, C18-1, or C18-2. And you may say, why not C18-0? Maybe that's the question. C18-0 is a very small proportion of our fat composition. C18-0 perhaps is like about 5 to 10% maximum, whereas C16-0 is the most abundant fatty acid we have. It's palmitate. The palmitate is perhaps in the range of 10 to 40%, depending on what the reason we chose the fatty acids we talked about are because they are representative of the fat composition that we have. So C18-1 is about 25 to 40%. C18-2 can be anywhere from 10 to 25, 30%. C16-0 can be anywhere from 10 to about 40%. And these are the most abundant ones. C18-0 is maybe number 4 or number 5.
Okay, thank you. We'll move on to the next question. This is from Gopika. She has asked if we could control the fatty acid levels, we could reduce the severity of COVID-19 and thus the death rate. So she's asking whether if we control the fatty acid levels, the death rate can be modified.
Well, that's the hope. That is essentially what the topic was about. I cannot control the obesity. For example, if I'm obese, I cannot control how obese I have become over the last 10 years or 15 years, because now I have COVID-19, I can't reverse what I have. So what is there as substrate is there as substrate. Now the rest is the breakdown of the substrate. And I mentioned that we don't know which lipase it is. So unless we know which lipase it is, and then designing a pharmacologic approach for that is going to be very challenging. So the best and cheapest and most relevant strategies, the tools we already have in our hands, are calcium and albumin, both of which bind the fatty acids generated. And therefore, the strategy is, okay, well, if we don't have drugs for that, I can't reverse obesity. Let's try to neutralize them, what we have.
Yeah. Okay, thank you. She also asked another question. Omega fatty acids with unsaturation are always prescribed for better health. Why it is acting in a negative way here?
Yeah, so omega is the location of double bonds here. And yes, there has been a lot of talk about omega, various types, omega-3s, omega-6s, where the double bond location is. There's also talk about the type of the double bond, whether it's a cis or a trans double bond. Point being, the mystique of omega-3s is been there historically for a long time. The relevance of it to these phenomena, I cannot comment on. I don't have an idea. Maybe there is, maybe there is not. So in general, and the other part is if you really look at the composition of our fat, what proportion are omega-3s? It's less than 2%. We don't have, whereas the omega-6 and 9s that we have seen, the oleic acid and linoleic acids, they're like 50, 60%. So the omega-3s are a very small part of our fat composition. It's not going to be relevant, at least at this time in where we stand in COVID-19, and as urgently as we have to act that we change the composition to omega-3. It's going to be very hard.
Okay. Yeah, thank you. And she has another question also. Whether the occurrence of severe pancreatitis is seen only with SARS-CoV-2 or with all types of coronavirus?
Yeah, so your question is, does pancreatitis happen in SARS-CoV-2? The first example I gave you was the SARS-CoV-1 virus in 2004. That's the autopsy data that I showed. So yes, other coronaviruses have a trophism for the pancreas too. The autopsy data I showed is from this year, from 5 out of 11 patients having focal pancreatitis and fat necrosis. So what we have so far, at least from the two main clinically relevant examples, is that they have a tropism for the pancreas. They do. Now, does pancreatitis happen in all? No, it does not happen in all. Is the lipase from the pancreas? Not necessarily, as I've put in that schematic. It's a question mark, big question mark there. Could be pancreatic, could be adipose lipase. There are 10 lipases we have in us. Which of them is doing this? I don't know. But there has to be some generation where the fatty acid is coming from. So that's the answer. So it's not that there is definite pancreatitis involvement in every COVID-19 case. No, that's not the case.
Okay, thank you, sir. We'll move on to the next question. It is from Pavana Kamath. He has asked, some children cured of COVID infection are showing severe inflammation of eyes, developing skin rashes and swelling. What could be the reason?
I have no idea.
Okay, yeah. So we'll move on to the next question, and it's from Sashwat Kumar Mohanty. He has asked, is there any changes observed in serum thyroid, parathyroid, or vitamin D level as they regulate the kidney calcium reabsorption?
Yeah, so there is a lot of talk of vitamin D and PTH. The perspective to keep in mind here is very important. So vitamin D helps build the calcium reserves we have in the bone. It helps in the homeostasis of that. And perhaps there is a so far uncharacterized role of how we mobilize that calcium also. But the acute hypocalcemia that happens within 2 days of these patients cannot be via vitamin D acute drop, because vitamin D is a fat soluble vitamin of which we maintain fairly steady levels. For me to become hypo vitamin D or have low vitamin D levels is not going to be an overnight affair. The drop in calcium is very quick. It cannot be explained by these. Moreover, if you think of rickets or osteomalacia, they don't have hypocalcemia. So they are bone deformities, but no hypocalcemia. The other part is vitamin D deficiency, sun exposure. So there are populations that do not have sun exposure in some cultures. Yes, they do have rickets, but does it necessarily lead to the bad outcomes in COVID-19? I don't know. So yes, I think my interpretation of this is that the hypovitaminosis D chronically over time does result in an impaired response to when the reserves need to be mobilized. If my bone calcium needs to be mobilized because of fatty acids consuming it, I may not have that good a response if I'm already low in vitamin D. But is that the exact mechanism how that happens? I cannot say. But take it for sure that there is no acute vitamin D drop happening overnight causing that hypocalcemia.
Okay, thank you. The next question, it is also related to calcium. It is from Sunil Kumar Gowda. he has asked, how does the calcium and albumin level go down even after taking a normal diet which contained required amount of calcium and albumin? How does the lipase action reduce the calcium and albumin level?
Yeah, it's not the lipase action that reduces it. It is the fatty acids generated.
Yes.
So as you saw, there's a very strong reaction between the fatty acid and the calcium, or the fatty acid and the albumin. So if I have a lot of fatty acid in my system, so if I'm obese, I'm going to mobilize a lot of few hundred grams of fatty acids perhaps. My serum calcium normally is 9 to 10 milligrams per deciliter. So maybe per liter I have 90 to 100 milligrams, or total in my blood circulation at any one point of time, I have half a gram of calcium. If I'm mobilizing fatty acids so quickly, I'm going to react with that and it's going to neutralize it. And then when there's overwhelmed, it's going to third space. So we have a limited capacity in the blood at any time. The typical example I give is, think of this like cash in hand. So think of a time when there was only cash and a bank, no checkbook, no credit card, just cash and a bank. Okay. So the calcium you have in your blood, or with a part of which is ionized, is that active cash in hand, which reacts with the fatty acids very quickly. But your cash in hand will get depleted by that reaction. So you'll need to pull more for the bank. And that's going to bring your total calcium down. The cash in the bank is the total calcium. That'll start going down. And if we don't replace it, which we don't, by medical guidelines, typically we are not asked to replace calcium and albumin currently. Conventional guidelines say that we don't replace calcium and albumin. So that will then result in a deficit in calcium, and then the fatty acids will be so much more, they'll overwhelm the system, and then cause endothelial injury, all those injuries. Third spacing will happen, and then we'll go into organ failure. So therefore, early neutralization and keeping those stores, that bank store, the bank account, up to date is important.
Okay, thank you, sir. So probably this will be the last question. This is from Ashwin Permal. He has asked, why SARS-CoV-2 have a specific affinity towards targeting fatty acids?
Yeah, again, let's go to the first slide. 9 out of 10 people will clear COVID-19 without any problem. So 9 out of 10, it may not have that affinity. Why that is, we don't know. But 9 out of 10 people will clear the infection on their own. It's 1 out of 10 who will go into the severe or really advanced stage. So in that subgroup, it may be the whole cascade taking place. That there is, as you mentioned, the ACE2 receptor is on adipocytes. ACE2 receptor, the virus has been found in the pancreas. That's where it may be doing the action, releasing the lipase, breaking the fat, causing fatty acid generation, causing eventually the organ failure. And it may be just that select subgroup. That is still unknown. It is still an evolving story. And we'll know that hopefully down the line as to what happens. But the autopsy data I mentioned, 5 out of 11 autopsies showing pancreatic involvement, it's a fairly significant number.
Okay. If you have time, we can take one more question. Or
Sure, I would be glad to answer. Sure.
Okay, yeah. So this is again from Sunil Kumar Gowda. He has asked, is there any case of obese person getting cured and their body responds to fatty acids after giving calcium and albumin treatment?
I'm anecdotally not sure about that. I know there is no documented cases there, but in a way you can say that the clinical course speaks for itself, that the patients who did not drop calcium, mobilized perhaps the calcium, were the ones who went home. The ones who dropped calcium went to the ICU. And my suggestion would be here, if you want to test this on your own, if you're a physician or working in a medical setting, just follow the trend of your patients. Just a little pencil and paper documentation of what was the calcium when they came in and where is it now when they're going home or going to the ICU. See the trends. You'll see it for yourself that whether this is happening or not. And the supportive care is very simple. If this is to be implemented, it's over the counter. It's all should be done by a physician under the supervision of a physician. And as I mentioned, it's supportive care. It is not going to replace any therapy. It's just supportive care. So observe the trends if you'd like. Apply the supportive care if you'd like. I'll leave it to your judgment.
Okay, yeah. Thank you for the excellent question and answer session, sir. Now I hand over the stage to Dr. Rukman.
One more question.
Thank you, madam, and thank you very much, sir. I think Professor Joydeep has some questions. I would like him to ask in case if he wants to.
There's one last question. How much albumin and calcium, what are the deciding values or parameters? This is from a clinician, Dr. Vinod Singh.
Yeah, that's a good point. So, yes, hi Vinod, how are you? So, the way I would look at it is this: every lab value has a lower limit of normal. So, if I were the admitting patient and a physician, I would see, hey, the calcium is 9. It's on the lower side, and if 9 to 11 is the normal at my hospital, depends on what, every place has its own normal. So if it's on the 9 side, and I say, is it going to hurt to give this patient 2 grams of calcium a day? And that only for another 2 weeks? Perhaps not. Okay, let me give him 2 grams of calcium and then test him again 3 days later and see how it goes. And same I would do with albumin. If the albumin is 4.5, I'd do nothing. I'd say, okay, let's just test a week later. But if it is borderline, if it's all on the lower limit of normal or borderline, I'd be more proactive. And it'll all go with the local resources, how much follow-up we can do. So once it's on that 9-ish or albumin is maybe 3.8 or something, I'd be proactive. Perhaps if it's 3.8, I'd say, okay, well, clinically you're not in that bad a shape, but you're maybe heading that way. Maybe give 25 grams of albumin IV. And let's see a couple of days now. Let's follow your clinical course and see if we need to repeat it and see how you do. Again, I would give both concurrently if possible. That's my opinion.
On the similar lines, Dr. Sharan Gowda is asking, intake of 1 egg or a glass of milk per day, will it manage the calcium albumin levels even without pancreatitis?
Yeah,
1 egg or a glass of milk?
Yeah, see, that's a tough question to answer because both the food, any food form that we take it in is it's not elemental, it's bound in some form or the other. So it's good if I'm a healthy person and my goal is to stay healthy, yes. In a preventative setting, that's perfectly fine. In the early therapeutic setting, which is the context of the whole discussion we've had, is early therapy. It's not prevention, it's early therapy. In that context, the milk and eggs approach will probably not help.
Right. And to reiterate, just to allay fears, is there any problem if we consume calcium and albumin? This is by, again, Sunil Kumar Gowda. If what happens if we take excess of calcium?
Yeah, so that's a very good. So, okay. So the answer to that is the normal intake of calcium is 1 gram per day. That's what's recommended. Normal intake of calcium, about 1 gram a day. So let me give you an example of water. So water, we are asked to take about 1.5 to 2 liters a day. If we take 10 times more, we can develop water intoxication. Water can be toxic if we take 10 times more. Now apply the same logic here. If we are taking 1 gram a day, I'm not saying that we take 10 grams a day, but somewhere in the middle, that 2-3 grams a day. If you're running a marathon, you may need 4 liters of water that day. So it's the same equivalence. There is some overdosing will not help. Be very cautious of toxicity. Prophylaxis or preventative strategies will not help. It is only in the early setting that it will be relevant. A fair judgment call would be that, okay, what is the serum calcium of this patient? How much should I give them? Or, 2 grams of calcium going from 1 to 2 or 2 to 3 a day, is it going to harm for a couple of weeks? I don't think so. 2 or 3 grams of calcium a day is perfectly fine.
Right. And finally, there have been 3 or 4 questions more from the kitchen. It's about buying what kind of oils we should use, and any comments on junk food and lifestyle, just to sort of close up on the real practical aspects of what we put on our plate.
Yeah, that's a great point. So that's a good question. Changing diet is not going to do anything in the short term. No. What we have accumulated, we have already accumulated. It's already there. It's already sitting there as visceral fat and can be hydrolyzed when needed, if we develop pancreatitis or COVID-19, whatever the scenario. Visceral fat takes 4 to 5 years to turn over. It's a very slow process. Studies were done in the 60s when they changed the diets of people. In fact, linoleic acid was a tracer they followed because it's an essential fatty acid. It takes 4 to 5 years to change the whole visceral fat. Now, from that standpoint, will a dietary approach help? Well, if the pandemic, hopefully it's not relevant and doesn't happen, but if the pandemic is so prolonged, maybe it will. I hope not. I hope that it's not that prolonged. Or if we get hit by a second scenario, may help. But now is not changing diet today is not going to help tomorrow. No.
Thank you. I think that's about it. There are no more questions on the YouTube also. Yes.
Thank you very much.
Thank you so much.
Thank you very much. Thank you very much for the scintillating question-answer session. We are extremely thankful to Vijay sir for being with us, especially in this odd hour. I think it will be around midnight at your place. Thank you so much, sir.
Oh, it's my pleasure. You have a very nice rest of the day, and hopefully we can combat this horrendous disease and stop it from progressing.
Yes.
Have a very nice day ahead.
I would like to tell the participants that our expert has shared his research paper and the link is given in the chat box. Now, I request Dr. Sudharani to propose the vote of thanks.
Thank you, Dr. Rukmini. On behalf of the organizing committee of this international webinar, Covinar, I express my sincere thanks to Professor Vijay P. Singh for his thought-provoking lecture. Thank you very much, sir. Sir, you have explained about the biochemical basis of the possible relationship between obesity, pancreatitis, and the pathological changes that are observed in COVID-19 patients. And also you explained the basis of how the fatty acids could cause damage to the mitochondria and subsequently lead to multiple organ failure. Thank you very much, sir, for sharing your knowledge with us. Thank you, sir. I also thank Professor Jaideep Raipudi, Professor of Physiology, PIMS, Pondicherry, for introducing the speaker as well as moderating the question answer session. Thank you very much, sir. I thank all the participants for their patient listening also. Thank you. I hand over to Dr. Rukmini.
Yeah. Thank you very much, madam. And thank you very much, Vijay, sir. Now I thank all the participants for your kind support and continuous interest and cooperation throughout the session. We will meet tomorrow in yet another exciting session at 7 p.m. Indian time. I repeat, it is at 7 p.m. tomorrow evening. Till then, bye. Have a great day. Thank you all.
Bye.
Thank you very much, Professor. It was a wonderful session. Yeah.
Oh, it's a pleasure. Have a very good one. Say my hello to Herb if you do meet him.
Definitely.
Yeah.
Thank you. So kind of you.
Thank you.